My name is Ken Ferraro, and I'm director of the Center on Aging in the Life course. And it's my pleasure to welcome you to our symposium on aging, families, and health. We're going to focus today on social influences on health lifestyle choices in later life. I believe you're in store for a great afternoon. In our society, with its emphasis on evidence-based medicine, health and healthcare are becoming very complex. We get dozens of messages each day about health issues. And that's a good thing, but the problem is that some of those health stories conflict. Is coffee good for you or bad? And if it is good, is there too much of a good thing? And healthcare is very complex. Health plans for many Americans change every year. So we learn what our health insurance covers, and poof, the next year it's different. You could argue that healthcare in the United States is a fabulous system, but you could also argue that it's not really a system. It's just disjointed and it's hard to figure out. And so, not surprisingly, what will the Affordable Care Act offer to persons in those health exchanges? Navigators. Yes, it's coming. GPS for healthcare. Well, many of us have found that when we're trying to negotiate decisions about health, protecting our health, or seeking health care, that we want some help in navigating. But I don't know about you, but if I'm in a whitewater raft and I'm headed down the rapids, I don't really want to push some buttons on my phone to get a call center for help on how to get down the rapids. So what do? I oftentimes turn to family or close friends, and I trust those people for some expertise or some guidance on how it is that I should handle the things in front of me. So today we're going to focus on this question of how families help us navigate the healthcare choices in later life. And even if our family members aren't asking, how could we offer stealth advice to help them make good, informed decisions? These are the types of questions we're going to address today. We've assembled 3 of the world's most prominent scholars on the topic to help us answer these questions, and I'm very glad that you decided to join us. Welcome. For those of you who pre-registered, you should have received a booklet with some information to help you navigate today and follow up on these issues. There's bios on our speakers, as well as some references for further reading and note cards. We'll conclude the day with an award presentation, a poster session, and a reception, so I welcome you for the entire afternoon. 3 organizations collaborated in making today possible. So the Center on Aging in the Life course and the Center for Families worked hand in hand to plan and organize this event. And you can see 2 of those logos up here, and they're on your booklet. It was back in 2001 that CALC launched its annual Symposium series. And over the years, we've attracted some retirees from Purdue to these symposia. This year, the Purdue University Retirees Association, or PURA, as many people refer to it, took it a step further and offered to co-sponsor our symposium. I'd like to invite Bob Bain, president of PURA, to offer a few words of introduction. Bob?
Well, thank you. PURA, on behalf of our 4,000 members, official retirees of the university, are very proud to be helping to make this symposium possible. This is kind of an experiment for us. It's the first time we have done so under the blanket of our Opportunities and Activities Endowment. And I see a number of retirees out there in the audience, so I think this is something that struck home. Pura is a great way that retirees can stay connected and stay active both mentally and physically and socially. So this really fits into our mission and purpose and the kind of things that we do, and we're hoping that this will be of great value to all of us. Thank you.
Thank you, Bob. And with the support of Pura, we are actually video recording the proceedings today. And it is our intent that we can make that available to people who were unable to attend today, as well as for instructional purposes. Thank you, Bob. Now, to help kick off our afternoon, I've invited Lindsay Wilkinson to introduce our first speaker. Lindsay is a doctoral candidate, not just a doctoral student. She's a candidate in sociology and gerontology, the dual title PhD program. Lindsay?
Thank you. This afternoon, I have the pleasure of introducing Dr. Deborah Carr. Dr. Carr is a professor in the Department of Sociology and Institute for Health, Healthcare Policy, and Aging Research at Rutgers University. Dr. Carr is also co-director of the National Institute of Mental Health postdoctoral training program at Rutgers Institute for Health, Healthcare Policy, and Aging Research. Her research has been supported by the National Institutes of Health and focuses on work and family experiences over the life course, bereavement and end-of-life decision-making, and the social and psychological consequences of body weight and obesity. Dr. Carr has authored or co-authored more than 75 articles and book chapters, and her work has recently appeared in the Journal of Health and Social Behavior, Journal of Gerontology, Social Science and Medicine, and The Gerontologist. Dr. Carr currently serves as deputy editor of Social Psychology Quarterly and Journal of Marriage and Family. And she is putting the finishing touches on a book for Rutgers Press titled Worried Sick: Why Stress Hurts Us and What to Do About It. Dr. Carr is also co-investigator of the midlife development in the United States and the Wisconsin Longitudinal Study. In addition to all of this, Dr. Carr plays classical flute and piano. She enjoys running and has recently taken an interest in hiking. This summer, she climbed part of the Alps and the White Mountains in New Hampshire. She is a remarkable scholar and a wonderful human being, and we are honored to have her here with us today. Please join me in welcoming Dr. Deborah Carr.
Well, first of all, thank you so much for that warm introduction, Lindsay, and Kat, and to everybody who's been such a gracious host on this visit so far, including my ride that picked me up to the airport yesterday at about 1:45 in the morning. So thank you. And I don't see her here. Maybe she's still napping, but we'll talk later. And let's see. I need to find my slides here. Laptop? Escape. Thank you. That's always the hardest part of the presentation. But again, thank you so much for your warm hospitality, both to Purdue and to Indiana. The only part of Indiana I've been to before today is that little part way up north between Madison, Wisconsin and Ann Arbor, Michigan. And it's very beautiful down here. So I really have enjoyed my time here so far. And what I'll be talking about today is a topic that is very relevant to the theme of the conference. And part of what I'm talking about is something that lots of us in the room know about already. How is it that personal relationships and the status of our relationships affect health and behaviors? That's something I know a lot of scholars in this room have expertise in. But what I'll be doing that's a little bit different is focusing on a set of outcomes that at least the young people in this room probably haven't thought about very much, but the older folks might have perhaps. And it's how it is that we prepare for the end of life. Not an uplifting topic, but an important topic that we all need to think about, and a topic that truly is sociological. And you'll see why that is as I go through the talk. And so I'll be talking about how and why family relationships affect end-of-life healthcare preparations. And despite these lofty claims by poets and scholars to say we're born alone, we live alone, we die alone, no one actually dies alone. Most people die surrounded by loved ones. Most people, when they think about how they want to die, incorporate family members into that. And not to ask Shumaros of a question, but just think about how you would ideally like to die. Okay, most people say they'd like to die peacefully in their sleep, in their home. Or if it has to be in a hospital where about 75% of people will actually die, it's surrounded by loved ones and family members. So again, this notion that we die alone has perhaps support by the sad, morose, poetic community, but certainly not by the research community or the medical community. And specifically, the type of care we receive at the end of life, which often requires very intense decision-making, and I'll say more about that later, is something that tends not to happen in isolation. We make these decisions with our family members, or at least we should, because the family members will be the ones living with the ramifications of how it is that one chooses to live or die. And so just colloquially, people talk about, if I'm ever a vegetable, pull the plug. But if you're the family member who has to be the one that says, yes, it's time to take mom or dad off life support, certainly you can imagine that they might have ripple effects, not only for one's adjustment as they deal with the death, but how they deal with their family members. So death, again, is not a solitary experience, nor is the dying process, which is actually just as important as the actual death. And so patient-centered care is something we hear about a lot when Ken was talking about healthcare earlier. But patient-centered care encompasses care that, according to the Institute of Medicine here, it's care that informs and involves patient and medical decision-making and self-management. So when we hear a lot in the medical community about patient-centered care today, the subtext is that it's an individual making these choices, that we as individuals need to be well-informed, and we need to articulate and be autonomous about what kind of health care we want or don't want at the end of life. But I argue, again, this is a fairly limited view, and when we talk about patient-centered care, perhaps we should talk more realistically about family-based care, of which the patient is just one part of that equation. So again, I just want to move us away from this notion of death as solitary and really bring it into the family, and especially family scholarship. So to get back to kind of nuts and bolts, I'll first start out with my aims, and we'll talk about why this topic is something that I think is important, and hopefully I can convince you of why it's important, what some theories say about why and how family members will participate in end-of-life decision-making and end-of-life preparations, and then I'll walk you quickly through results from a couple of studies from a bunch of data sets, and then introduce you to a new data set that I'm collecting that I think will actually be a really nice set of materials for lots of us interested in family-level decision-making and family dynamics. So just a couple of the aims. First and foremost, I'm going to investigate whether and how the legal status, trajectory, and quality of one's romantic partnership affects advanced care planning. Again, that sounds all very, dry, but the motivation for one of the questions I'll look at today is this observation that we found in the family and health literature. Right? We know that being married is good for our health. On average, married people live longer, they're happier, they're healthier, etc. Of course, it depends a little bit on the quality of the marriage, but marriage protects us. But there's an interesting wrinkle. There's been a variety of studies that show that it's not all marriages that are protective. It's legal marriage. Marriage tends to give us more benefits than non-legal marriage or cohabitation. So why is that? Likewise, first marriages tend to confer more health benefits than higher order marriages. And my question is, okay, given that the marriage is considered the one form that protects our health and keeps us behaving in healthy ways, does that extend to this outcome of advanced care planning, or how we prepare for end of life? And one of the arguments I'm going to make is that end of life planning is a health behavior exactly as smoking or drinking is a health behavior. We don't smoke or drink now, at least some of us don't smoke or drink now, because we know it'll compromise our quality of life down the road. But likewise, end-of-life planning, meaning telling doctors what kind of medical treatment you want at the end of life, or what kind of life-extending treatments you do not want at the end of life. Making preparations for that now is a health behavior that might actually spare you duress and intrusive and futile care at the end of life, and likewise duress for family members. So again, that's some of the literature I'm drawing on, this notion that our family relationships now might help us to engage in protective health behaviors, even if we don't see the fruits or returns of those health behaviors for quite some time. So that first study here of how it is that the legal notions of aspects of our relationship and the quality of our relationships affect advanced care planning is something I'll study using data from the knowledge networks. Then we'll talk a little bit more about what happens in the relationship, and so I'll study the ways that relationship dynamics, meaning whether it's a close-knit relationship or a conflictual relationship, how those type of relationships affect not only whether you prepare for the end of life, but with whom. Who do you engage in the process? And I'll use two data sets here, New Jersey End of Life, which is one of my surveys, and Wisconsin Longitudinal Study. And, you know, this question kind of seems like a no-brainer. We might think, of course you plan with the family members you're closest with. But as you walk through the talk today, you'll see there are a couple of tensions. You know, if you want a living will or a document that tells people what kind of end-of-life care you want at the end of life, on one hand, it's sensible that you would go to those family members you're closest with and that you can talk to. But let's say you have one son or one daughter who you just don't get along with, and you know that your end-of-life care is going to fall in their hands. You might feel all the more compelled to put your preferences in writing to kind of wrest the decision-making process from that family member who maybe didn't always have your back in life. So again, there really is an interesting puzzle here. Is it that we do a certain behavior in order to help our family members and draw on their strength? Or likewise, do we engage in end-of-life planning, meaning writing a living will as a way to forestall the possible outcome that a family member who doesn't have our best interests in mind might make a decision that doesn't particularly benefit the dying patient. So there is some dramatic tension here that it really could go either way. You'll soon see the answer. And then if there's time at the end of the talk, I'll tell you about a new data set I'm collecting now called the Wistful, because we always need cute little names for our data sets. But this is a study called the Wisconsin Studies of Families and Loss, which is a study of recently deceased older adults. But more importantly, it's interviews two of their next of kin, a spouse and a child or two siblings, and really hearing from those multiple next of kin what happened when this person died. What were the sources of family conflict? Did they receive the care they want? If they didn't, what are some of the sources of that? And so it's a data collection that's in the field now, but it's just coming out of the field, and so I'll be able to present a couple papers on this at the gerontology meetings in November. And again, it'll be available to the research community for those who are so inclined to analyze these data. So that's the big picture of what I'm doing. Just to give you a bit more motivation, for those of you who are new to the topic of advanced care planning or end-of-life decision-making. Advanced care planning is the big label we put on a couple of specific behaviors, such as writing a living will. But we engage in end-of-life planning, meaning putting down on paper the medical treatments we want or don't want at the end of life, and likewise appointing a family member to be our advocate, to be our spokesperson, to tell healthcare providers what kind of care we want at the end of life if we ourselves have cognitive impairment and are unable to communicate that decision for oneself. But why do we do this? Okay, the rhetoric is that we do this because it helps us to ensure a good death. If we call the shots, if we say, no, I don't want a feeding tube, then you presumably will get the kinds of treatments that are consistent with your desires. And I would argue, if you plan at a family level, with the desires of your whole family member, with your whole family unit. And I suspect some of you in this room, unfortunately, have witnessed the death of loved ones that were not good deaths at all. Right? You've seen someone hooked up to wires. You see someone dying in a way that you find not comfortable for them in any way. And end-of-life planning is intended to forestall those type of problematic deaths. It's also intended to forestall or to just get rid of family-level conflicts. If there's no end-of-life planning and, let's say, one sister decides that we should pull the plug on mom and all the other siblings say, no, don't do that, clearly you can't both have your ways. And think about what that might mean for family relationships after the death. This could be a source of real conflict. And so all of those reasons leads us to believe that, yes, we should put our preferences on paper because it will lead to better outcomes for the family members and for the dying patient. Okay? So that's us as kind of advocate speaking. But as a researcher, we often know that you can't ascertain causality that easily. Is it really the advanced care planning that helps people to die better? Or is it the kind of people who do advanced care planning, or educated, smart people who get along with their family members in the first place and their death would be as good as a death can be even in the absence of the planning? It's really important to parse out what is the lever leading to this outcome if we do want to invest our time and energy into public policies that enhance these type of behaviors. So that's a kind of secondary aim of what I'm talking about today. If I find out it's only happy families who are doing end-of-life planning, and then they're kind of happy as one can be after their family member died, is it really that it was the legal documents that helped? Or was it these people would have had actually a fairly fine outcome, again, given as fine as one can be after a loved one dies, in absence of those documents? So again, we always have kind of a policy and practice agenda, but then a scientific agenda of trying to figure out exactly what is the causal mechanism here. Again, advanced care planning, I think, is considered a core aspect of the patient-centered care that we heard about earlier, but I think the emphasis that we've had on the individual level really conceals just the importance of family in this process. Again, just as family is important in helping with all forms of health behavior. So that's the motivation behind the talk today. And so just to give you a little bit of background about why we care about this topic and how can you plan for death. Some people will say death happens. You know, my grandmother used to say you can die slipping on a banana peel, so why plan? I think something got lost in translation from Polish there. But we all know that, you know, you could die, an anvil drops on my head. But no, I mean, we think about those things. And when I ask people to tell me what is the ideal death, most people, a lot of men say, I just want to drop dead on the golf course, you know, West Palm. You're not going to die that way. Very few of us are going to drop dead on the golf course or at a great sale at Loman's. I mean, whatever is your ideal way to die. We're not going to die that way for the most part. And why is that? It's how we die. And it's not actually the event of death that is important. It's the process of dying, which is getting longer and longer today than it was in the past. So again, just to think about gloomy topics for a moment, there are about 2.5 million deaths in the United States each year, and almost 3/4 of them happen to people over age 65 and older. So again, as much as we see televised deaths of young people on television, it's truly devastating. That's not the statistical norm. Age is one of the biggest predictors of mortality. But we think about not only when people die, but how they die. The 3 leading causes of death today are heart disease, cancer, and upper respiratory disease. Again, these are diseases that unfold and unfurl slowly. There's a very long and increasingly long duration between the time you're diagnosed with the condition and the time that you ultimately die. And that's a period that some scholars have referred to as the living dying interval. And so it's filled with both good and bad things is one way to think about it. At some level, it is filled with long and prolonged suffering in some cases, but also it's a time period that the family can prepare for the future and use that time to think about medical decision-making, financial planning, as some of you are interested in. And so it's really something that's an interesting period to study. Again, and we know that that living dying period is long and prolonged because with medical technology today, people kind of know that they're dying, and that period of dying is prolonged because we can sustain the lifespan, even if it's not necessarily a healthy lifespan. But also that living dying interval is not always filled with times of being mentally aware and able to make decisions. We know that specifically at the very end of life, there's physical health decline, psychological distress, and very importantly, cognitive symptoms. And all of this means that the individual dying patient might not be the one who's able to advocate for him or herself on the deathbed, and the family members really have to be the ones to intervene and talk about whether treatment will be accepted or rejected or requested or ignored. And also during that time period, these decisions, they're difficult, and there's no right answer. Whether we want treatment or not, there's no right or wrong answer. It's based on a variety of things that I've written about in other papers. Some has to do with religious or spiritual views. We know there are race and ethnic differences, our faith in the medical system, our reliance on faith versus science. There are a whole collection of factors that determine whether someone wants to, again, be strung along or to have the plug pulled, call it colloquially. No right or wrong answers. But the important thing is that people get what they want. And if they do not put it down on paper or have an advocate, there are higher chances that one will not get what they want. And that's part of the reason why, again, the family is so important. There's some evidence that suggests that the default treatment, if you do not say, hey, stop treatment, you will receive any treatment available because that's what doctors are trained to do. But also there's some evidence, and sketchy evidence, that people who can't afford to pay, especially blacks and Latinos, sometimes may not get the treatment they want. We know that blacks and Latinos on average want more life-extending treatment, but sometimes due to things like compromised ability to pay, they might not get it. So these errors can happen on one of two ways: getting what you don't want or not getting what you do want. So again, all the more motivation for doing this kind of planning. Again, this is just a little picture here to think about, but why should people plan? Sometimes people think they're going to make plans and put down on paper what kind of treatment they want when they're really sick, really at the end of life. I don't need to think about it now. I'm 40 years old. I'm going to live forever. But as any of you know who has watched a family member die, Death is not really predictable, right? We all have seen a family member that has a chronic illness and they really crash. And we're like, oh my God, they're going to die today. Then they bounce back, and our hopes are kind of raised. We're like, oh no, look, they recovered once. We don't need to do advanced care planning. But then what happens? They go up and down, up and down. And so there is this unpredictable element. So the fact that this kind of is a portrait of what kind of death looks like, this unpredictability, again, is all the more reason why people need to do this planning. And planning done too late is not really efficient. You can't do, and you have someone write a living will once they're already on a very severe decline. So again, this is all by way of saying end-of-life planning is something that should be done early and often. Okay. Again, here this just recaps why this planning is so important. Dying older adults suffer from a variety of major problems that stop them from making their own decisions. And again, as I pointed out earlier, without planning, there's a heightened risk of unwanted or futile medical treatments. And in fact, there was a study that came out this week. This is something like 15 to 20% of medical treatments received at the end of life are futile. And what do we mean by that? Futile treatment is considered treatment that maybe treats a symptom, maybe helps you breathe a little bit better, but it doesn't help the overall body and it doesn't sustain lifespan. So what you're often doing is kind of putting a bandage on one symptom, but you're not enhancing overall quality of life, and you're kind of stringing people along beyond what some would deem a healthy and worthwhile and pleasant life. End-of-life care that is extended over very long time periods is very expensive. It's also a source of psychological duress, again, watching a family member die. But again, the point I keep coming back to, it's important to do this planning, because if you don't, those decisions are going to be left to children or to spouses or to siblings who might not know what the patient wants, or they might disagree with one another, and they create, again, a lot of difficulty both for the patient and for the full family. So again, just put a couple specific labels on some of the outcomes I'm looking for. I've been telling you so far what advanced care planning is, but there really are a couple main components. The living will is what specifies your treatment preference. Your DPAHC is the person that you name to be your advocate. Those are two things that, two policy levers that actually you all may have had the opportunity to do already. Due to the Patient Self-Determination Act, passed in 1990, it's required that all federally funded hospitals and nursing homes give patients the opportunity to execute advance directives. So all of you have the opportunity to do this, but not everybody does. Only about a third to half of all Americans actually engage in this behavior. And just to put it in context, if you go to the hospital, is that really, and you're all stressed out, is that the moment you want to be doing this? You might not have your family members there with you. Just to tell a personal anecdote, a few years ago I broke my ankle and it was bigger than my head, and they took me to the hospital, and like the second question they asked after insurance card was, do you have a living will or advance directive? And I sheepishly said no, but I study them. And partly, I was 35, I had a broken ankle, I wasn't going to die. But think about that, I was 35 at the time, but even if you're 75 and you go in with a coronary event, your head is not at the place that at intake you're going to sit down and think about these issues. So the opportunities are there to do these things. Everybody has this opportunity, but often the time in which they're invited to do so is not a time that someone's in a place to make that kind of decision. Again, but given all this talk that we need living wills and we need DPHCs, there's a lot of evidence showing that those documents alone don't always work. You might have a living will, but it's in your freezer where some people keep them, or it's in your safe deposit box. It's in New Jersey, you're in Florida. When you have a heart attack, it might not be of value. So again, on the whole, it has value, but it doesn't always get used or implemented in the way it's intended. So as a result, we also encourage people to just have informal discussions. Not legally binding, but sit down with your family members. It's usually advised to do this around Thanksgiving, and talk about what are your preferences. Telling a loved one, again, if I'm ever a vegetable, pull the plug, that has no clinical translation. You need to have conversations that are a little bit more complete. But what I do want to convey here is that just family members generally knowing one another's orientation toward wanting treatment or not wanting treatment, what they consider a life worth living. These values are important to convey as well, because they help, again, the family unit to come up with a decision that's ultimately good for both patient and family members. So this, again, is what we are supposed to do, but very few people do it. Only about a third of older adults today, anywhere between about a third and half, have a living will. It differs by samples. And if you don't, you're at risk of receiving those treatments that you don't necessarily want. So these are the components, or what people are suggested to do. And I'm going to make the case that whether we do these things, with whom we do these things, is very much shaped by our family relationships. These are things we tend not to do in isolation, and the extent to which we do them and who we engage, who we appoint as our decision maker, might be related to the quality of our relationships. Again, just as so many other health behaviors are linked to the quality of our relationships. So that leads to this next slide of how is it that families shape advanced care planning. This just recaps some of the points I made earlier, but I think we can think about this as really a proactive health behavior that we do to protect ourselves from unwanted treatment or wanted treatment we don't get, as well as family members from distress. We know that family relationships protect our health and our health behaviors. As mentioned earlier, not all relationships are equally protective. Marriage more so than cohabitation, good marriage more so than bad marriage. And you'll hear more, I suspect a little bit later, about why and how it is that our family relationships bolster our health. But one is pretty straightforward. It's social support. If we feel that we matter to people, if our family members love us and make us feel encouraged, we might be more willing or able to take on a health behavior that could be challenging to do, especially something like end-of-life planning. Even those of us who think about death 24/7 as part of our job, thinking about our own death, thinking about our family members' death, that's a difficult place to go to. And again, that cushion of feeling love and support sometimes emboldens people to think about these matters. But then by the same token, Deb Umberson and a couple of other folks working in this area show that our family relationships are a social control mechanism, that our family members make us do the right or healthy thing. So, again, I study widowhood, and we know that oftentimes if a wife dies, her husband will die shortly thereafter. And it tells a very lovely romantic story of this man dying of a broken heart. But, the data shows not necessarily that. It means the woman who gave him his healthy meals and gave him his heart medication every day is no longer there to keep him healthy. So again, there's a social control perspective, and having a loving spouse or child say, now you need to do your living will now, might, again, push along the process. So our family members control us in a way that is good, although sometimes it can be annoying. And then likewise, they give us support. So again, the feeling that we can and should do these things that protect our health because they help us in the larger family unit. So those are the ideas that underlie this talk. Again, lots of stuff, but we'll hopefully come up with some good answers soon. And just to go through the research objectives, I'll show you some slides and some tables, and we'll talk results, and then we'll open the floor to Q&A. Again, first, a very straightforward question. How do marital equality and parent-child relationships affect whether and with whom one does advanced care planning? That's from the New Jersey end-of-life data set, which I'll tell you about in a minute. And secondly, what kind of planning do you do? Do you do just the legal documents or also have conversation? That matters, because if someone fills out a living will on their own and they never show it to anybody else, probably not going to be helpful. And that might actually be the kind of thing you do if you have really lousy relationships with your kids. I'm going to write a living will and I'm not going to tell them what's in it. You can imagine these kind of things happen. That's not very helpful. But rather, if you do just formal planning, not always the best thing, but if you do it in tandem with the conversation and you work on it together, that's considered kind of the ultimate outcome. Then who do you choose? It's an interesting question. People ask me this, and reporters ask all the time, who do you ask? Who do you ask to be your advocate? Is it the person you're closest with? Or not? And just to give one anecdote, sometimes you're in the newspaper commenting on something, then you'll get these random letters or phone calls from strangers. Some of you as academics know this. And I was quoted in the paper something about advanced care planning, and I got this long impassioned email message from a woman in, I think it was Ohio, not Indiana, and she didn't know me from Adam, and she emailed, she's like, I'm so devastated. I am my mother's closest. I'm her best friend. My mother I know loves me best, but she asked my sister to make her decisions for her. And why is that? And again, her pain was just palpable in the course of this email. And I said, well, sometimes you don't actually choose the one that you love most. If they're too attached to you, they might not be able to make the hard decisions. Sometimes it is the more practical child who is, Jill stuff, who might not necessarily be the warmest child. We choose children and family members to do things for a specific reason. But I think also it's important to figure out, how do the quality of our relationships and with whom dictate who it is that we choose, that we bring into this very difficult role. So that's something else I'll show results on. Then the next question is, to what extent do married and cohabiting people differ with respect to their advanced care planning? We know that married people tend to have better health and health behaviors, but why? Like, why is it that cohabiting relationships do not push along the same positive health behaviors as marriage? And some of you probably can think of the answer now. If you fall asleep before I'm done with this talk, the answer is the relationships are less stable. If there's someone you're with who's in the fine for now category, you might not be actually thinking about them by your bedside in another 20, 30, 40 years. So again, it's not just the structure of the relationship, but what we imbue in these different structures, whether it's a shared future orientation, a sense of commitment, what have you. So that's, again, analysis based on the knowledge networks. And then, do these patterns, why is this happening? Why is it that we see cohabitors not planning as much? Is it really due to something about the relationship? Or again, getting back to our causal discussion earlier, is it something we call social selection? Sometimes it looks like we belong to a social category that kind of brings us bad things. On average, cohabitation is worse for us than marriage. But then you step back, what kind of people are cohabiting? They tend to be younger. They tend to have less money. So again, is it something about the relationship or something about the kinds of people in those relationships that either impel us toward or take us away from a particular behavior? So that's one of the secondary aims here. If we do see a difference between married and cohabiting people, why is it? The relationships or those things that get us into the relationship? So all kinds of stuff we'll be talking about. Before I go into data sources, does anybody have questions on any of the core concepts or ideas? Oh, good. I just needed a sip of water. Sorry, I'm coming down with the cold. So data sources. Many of you are expert data users. I know we have Midas and HRS and N-Shape people in the room. There are a couple more data sets of aging, a couple of which you'll learn about today that I've done these studies on. And just to give a little background about how this happened, before I started doing this, there were very few surveys that asked people about end-of-life issues at all. And I think there was maybe one survey. And when I was a grad student, I worked on the Wisconsin longitudinal study, and I stayed with it. And I was very, very fortunate that the PI of the study, Bob Hauser, was very open to letting his graduate students write questions for the survey. So back about 10 years ago, I wrote a series of questions about end-of-life planning. Just, do you have a living will? Did you appoint someone as your advocate? Who is it? Why did you do this stuff? And luckily, I was able to get those questions on the Wisconsin longitudinal study, which is a sample of a total of about 10,000 men and women who graduated Wisconsin high schools in 1957. So they're now 70 years old. So it's a great, huge sample of white people of a particular cohort living in Wisconsin. And so I was able to answer some really interesting questions with that data set. But it dawned on me that our whole nation is not tall, white, conscientious people from Wisconsin. We have a much more diverse society than that, so I went and got some money, fortunately, from NIA to replicate aspects of that study where I am in central New Jersey that has a tremendous racial and ethnic diversity. So I have a much smaller survey on end-of-life planning that has good numbers, reasonable numbers of blacks, whites, Latinos, and Asians. So I could really look to see whether the processes that we see going on among white Wisconsinites can be replicated elsewhere. So those are two papers that just came out in Journal of Gerontology, and I'll walk you through the findings of those. The good news is even though they're totally different samples, the results are pretty much similar, which is nice. It shows that there are some general human principles, and you'll see what those are. And then finally, my marriage cohabitation contrast paper is based on a survey called Knowledge Networks, which is one of these national surveys of, this was a very interesting one, of couples. And the design of this study was really to find out how do couples meet, what helps couples have good versus bad relationships. But they had a module competition, so people could submit modules, and I sent in some questions on end-of-life planning to figure out how do couples negotiate this, especially if they're not married, especially if they're young, are they even thinking about these issues? So luckily, they took my questions. Again, all the stuff you see here is because I'm very fortunate to be supported by really good, nice people who give me money in survey space, and so I'm able to do this work. But again, this is a way to look at kind of younger people in couples. What are they thinking when it comes to their future? So those are the data sources. Outcome measures, again, I try to use the same outcomes in all of the different data sets. The outcome here is just advanced care planning. Do you do formal and informal, which is considered the best, the legal stuff and the conversations? Conversations only or none? None is considered the worst. And then also, who do you choose as your advocate? Do you choose nobody, which is the modal category, your spouse, your child, or someone else to try to figure out how these things go? How do I get at family relationships quality? Again, do you plan with people that you're closer to or not? I use a couple of different measures. One is overall family functioning, just to get, does a family make decisions together? This is a 10-item scale, and so it's a composite of items such as in times of crisis, we can turn to each other for support. We're able to make decisions about how to solve problems. Again, you would think that a family that functions well and makes decisions well together might be more likely to do this kind of planning. But then we also care about relationships with specific people. I want to know, do you choose your spouse when you have a good relationship or when you have a bad relationship? So I want to know your relationship with the specific person who you might be naming as your advocate. So again, the positive and negative interaction scales that capture how it is you get along with your spouse and how you get along with your child. And these are probably familiar measures to many of you, the positive and the negative. So again, in the interest of time, I'll just kind of summarize a couple results. First, for the New Jersey end of life. I have the tables up here, but I wasn't sure how big the room was going to be. The font is small, so I'm going to stay away from the tables, though you can look at them if you like, and focus just on the findings. In my New Jersey data, what do I find? That people with better functioning families, those families that got along better, they're almost they have about 3 times the odds of discussing their end-of-life plans, and also of doing the 2-pronged advanced care planning. So on average, you can say those families that function better are more likely to do the 2 most effective types of planning, those types that involve conversations, either conversations alone or conversations with the legal documents. But again, that suggests that planning is happening among the people who might actually do fine in the end anyhow because they make decisions well together. What else do we find? That, again, if you're a married person and you can name your spouse, you can name your child, you can name someone else, maybe a sister, neighbor, you can, on average, you tend to choose those who treat you well. So if the more emotional support you get from your spouse, the higher the odds you turn to your spouse. So again, if we have a spouse that never listens to us, who seems kind of like a jerk, we don't appoint him or her to bring him into the fold. We just leave him by the wayside. Like, you know, you go with your spouse if they treat you well. If you have a spouse that criticizes you, you're far less likely to choose your spouse, which means you're more likely to turn to someone other than your partner. And again, I think this speaks a lot to the theme of the conference here of our relationships over the life course definitely shape how we behave. And think about that. If you're the spouse and you're not the one in the decision-making position, that's a pretty profound situation to be in. Likewise, when it comes to kids, this was kind of an interesting finding. I think it'll be interesting to people in that corner of the room. I find that people who get more emotional support from their children are more likely to appoint a child. That makes sense. If you're close with your children, you're more likely to appoint them. But there's also a funny finding, also higher levels of criticism for a child, from a child, meaning your kid always criticizes you. It makes you more likely to choose a child as your advocate. And so some of you might be thinking, is it a child that just like browbeats you into choosing them? You must pick me. No, what it is it's a function of how these things were measured. The questions are, how do you get along with your children? And our interpretation is that if you have one child that criticizes you a lot, where are you going to go? To another child in some case. So again, we don't know exactly why that is, but I think in this new Wisconsin study I'm doing, I'll be able to really get at individual level family relationships and how they help you. And we know sometimes there might be conflict with one child, which means the relationship with the other children are strengthened all the more. Again, some of you might be nodding that you have kind of good kid, bad kid. There are some kids you turn to for some things and not others. And that might be what we're seeing there. So it's not necessarily that you choose the child that criticizes you. It's there is a child that criticizes you in the family, and then you turn to another kid to take on that responsibility of decision maker. Okay. So again, that's some of the main findings with the spouse, the good relationships, you bring them into the fold. With the children, the good relationships, you engage them, or you also engage a child as a way to fend off the negative behavior from another child. Now that is too small. Okay, so we're just going to skip the results. These are just results if anybody wants to see them. So again, on the whole, we can see for both New Jersey sample, and again, I have almost exactly the same results for the Wisconsin study. It is the good relationships that foster planning, okay? And just to foreshadow one of the policy implications, you know, this suggests, again, if we now really try to force people to do end-of-life planning, will it work on people who have bad relationships, or is it the fact that your relationship is already strong the issue that's going on here. I think we have a partial answer that says, yes, that might be the case. We don't know that kind of requiring as a policy intervention people to plan is necessarily going to be good if they're forced to do it with family members who might not be on their page. So again, that's something we can talk about later, but I think there are implications for policy and practice here. So now we can kind of switch gears a little bit to that next question of the married cohabitation gap. Okay, so this is data from the Knowledge Networks panel study. And these are just, for starting, just straight bar charts, just to get a sense of what the magnitude is like. And so the red bars are cohabiting people, the blue bars are married people. This is a sample of 18 to 64, and some of you were thinking, why are we studying cohabitants as a bunch of college kids? No, that's not the case. One of the most rapidly growing groups of cohabitants are older adults. And we know that with high levels of divorce for baby boom cohort, and gray divorce, as Susan Brown calls it, we have large and growing numbers of couples in their 50s and 60s who are romantic partners who maybe are not legally married, and they're cohabiting. In some cases, they live apart together, meaning that they live apart, but they're very much a committed couple, and perhaps they might be thinking about one another as potential end-of-life planning partners. So again, cohabitation is not just for kids anymore. In fact, it's something that's becoming grayer and grayer each coming year. So again, this is an important population that we need to consider when it comes to a variety of health and health-related behaviors in later life. But to give kind of the quick answer here, what's going on when it comes to end-of-life planning? Let's see. So here, this bar chart over here is kind of whether you do no planning, formal only, discussions only, or both. That's kind of the legal aspects. Over here, it's who do you choose? And a couple things that should jump out at you, because these are young people, so not that many of them planning at all, but cohabitants are far more likely to have done nothing, and they're less likely to do the two superior forms of planning, discussions or both. So again, you can take away the point that yes, it's those in legal partnerships are more likely to do planning. And then likewise, if you look to see who are they choosing, this is really interesting. Again, most people choose no one, but married people are far more likely than cohabiting people to choose their romantic partner. And again, that's a teeny tiny amount. Think about this person you're living with who is presumably love of your life, at least for now. Only 10% are choosing that person to kind of be the one by their side that helps them at the end of life. And I think that again, it might be another interesting indicator for those of us who are interested in marriage to get a handle on what happens in a marriage and what future orientations mean in a marriage. But you can also see the cohabitants are more likely, again, those are small bars, but that's a significant difference. They're much more likely to choose someone different altogether. You know, who are they choosing? That's an interesting question. So that's the sheer pattern data, but why is this, okay? And so again, the next chart is too small for many of you, so I'll just kind of set it up here. So we always want to figure out what's going on here. Are the cohabiting people not doing end-of-life planning and not engaging their partner? Again, because of these selection factors, maybe they're younger on average. If they're young, they're healthy, they're not thinking about this at all. Or could it be that this is the relationship that's considered fine for now? Maybe you don't see a future with this person. So what we did next is we took all the cohabitants in our study and we broke them down into different subcategories. We know that cohabitants differ. There are some who are together for now, you know, and you expect it to end. There are others who are in it for the long haul, who intend to marry. There are all different stripes of cohabitants. When you glom them together in any kind of study, whether it's a health study or a health behavior study, we're going to have an incomplete portrait. So that's the next place that we went to here. Now that is too small for you. Yeah, so what I think maybe I will do, I'm doing the wrong way, is I will summarize the findings here. Again, it's a lot of numbers. I don't know how clear it is, but I will cut to the chase. When we broke down cohabiting people and put them into different categories of those who were cohabitors who planned to marry, cohabitors who didn't plan to marry, again, I have a bunch of tables here, but I'll just kind of cut to the chase here. We actually see that cohabitors who plan to marry, once you control for everything else, especially age, they don't particularly differ from married people. So cohabitants who plan to marry their partner are just as likely as married people to do the planning and to engage their partner in the planning process. Okay? We'll put things here. But of married of cohabiting people who do not intend to marry their partner, there is a huge gap. The cohabitants who don't plan to marry their partner are far less likely to do any kind of planning, and the main explanation there are a couple variables that are built into our models. It's commitment to the relationship and quality of the relationship. We ask them, how likely is it that you'll still be together? What is the quality of the relationship? So again, the reason cohabitants who don't plan to marry are not naming their partner as their DPHC or engaging them in planning is they don't see a future with this person. I think this is kind of perfectly sensible and perfectly plausible, but I think it's a find that we might want to carry over into our other studies of health and health behavior. Maybe cohabitants don't make us behave as well as a spouse would because we don't have as much of a vested interest in a cohabiting partner who we don't particularly see a future with. So that's less of kind of a public healthy message, but more for a message for the family researchers who often use a big fat category of cohabiting versus married, but forget all these gradations therein. And if you glom them all together, you're going to have results that are not very crisp and perhaps not very accurate. So those of you who are cohabiting with a partner, figure out tonight whether you think you're going to stay with them forever, and then go do some advanced planning. If not, just keep your eye on someone else with whom you do see a long-term future who will probably be a good advocate for you at the end of life. But all of this suggests, again, that the way that people involve their family members is fairly rational. You turn to those who support you. You turn to those who will probably make a decision that is consistent with the decision you want. And you do early planning now with someone who you foresee down the road in the longer haul. So again, it all gets back to that main point. If we don't die alone, we die with those people who are nearest and dearest to us with whom we envision a long-term future. Because even older adults in their 80s or 90s sometimes envision that death is not until far off. We don't like to think about death. We push it off into the future. And so we like to think only about very long-term persistent relationships as being those that will kind of protect us through the dying process. So those are all the findings that have been collected thus far. Again, I'm happy to talk about any of them in detail and try to make some of the numbers bigger for those who are so inclined. But I just want to give kind of a little advertisement of this other project that I'm really excited about that will help us to answer questions that we haven't been able to answer thus far in end of life. And so, this is a spin-off study that I did called the Wisconsin Studies of Families and Loss. And if you remember earlier, I told you about the Wisconsin Longitudinal Study, which is a survey of all the men and women in Wisconsin who graduated high school there in 1957. They're now in their 70s, and they are dying. And I know from our surveys when they were alive who did advanced care planning. I know everything about their lives, and so I thought it would be really cool as a bereavement researcher to find out how their family members adjusted their death based on all the stuff we know about their lives, but more importantly, to get multiple perspectives on what are conflicts in care, what happens at the end of life, and more importantly, if there are conflicts in care, what does that mean for the family dynamics down the road? Again, I'm sure every single one of you can think about either in your life or in a friend's life some conflict that happened, whether it's over a spoon, who inherits the spoon, or on the deathbed, or alternatively something much more profound about the end-of-life decision-making. So what we basically do is after these Wisconsin longitudinal study participants die off, I do this big tracing. We locate two next of kin. In most cases, it's a spouse and a child, but in some cases, they're single people, so it'll be just a child, just a sibling. And then we interview these next of kin about the conflicts about end-of-life care. Did the living will work? Did it create problems? Were there disputes over who was named as the DPHC? What was the death like? And then also, how were you all doing, and how were you adjusting to this death? My target sample size is 1,450. We're a little more than halfway there. We have 743 interviews completed. Some of you, including NIA, will say, why do you need so many people? It costs a lot of money. Well, part of the reason why, it's a study of individuals, but the unit of analysis is really the dyad, and I want good numbers of different types of combinations. And especially those people who are in kind of what we consider, atypical family relationships, unmarried people or childless people. It's going to be, we need a good sample size. So if you're an unmarried childless person, maybe it's an interview with two siblings. But I think there are a lot of people who are aging today who do not have by their side a spouse or children. Even though this is a conference on families, there are increasing numbers of people who do not have those traditional family members around them when they die. And I think we really need to know what their challenges are of aging. So this is just a little sneak preview. This is how the individuals fall out. The individual people interviewed, this is how they relate to the decedent Okay, most of them are spouse, partners, or children, but this gives you a sense of when I have combos of respondents, this is who they are. So not surprisingly, the majority are spouse, child, child, child. Let me go down to other, which could be something like neighbor, neighbor, friend, friend. And so that's where we're going now, and I have all this data to mine that I'll be talking about at ASA, but this will help us again to figure out, does planning help? We can study that prospectively, and for whom? Do we get multiple competing perspectives on this? And I think this is the important question of, does end-of-life planning help or hurt, and for whom? Again, this is a contested topic. I recognize that. Oops, I keep going the wrong way here. There are real implications for policy and practice here. This whole notion of end-of-life planning being a bad thing was something perpetuated by Sarah Palin a couple years ago. I'm in Indiana, so maybe some people do like Sarah Palin here. But as you might know, just to give this, why this is so policy relevant, I keep hitting the wrong key here. Some of you might know, as part of healthcare reform, a couple of years ago, Obama proposed that part of the, as a Medicare beneficiary, there are a bunch of stuff you get, right, a bunch of benefits. One was just a really simple benefit, was that all Medicare beneficiaries would get one kind of paid for doctor-patient consultation session regarding end-of-life decisions. You, your family members sit, talk to the doctor, it gets the conversation going. You can say whatever you want. You can say, give me everything, give me nothing, but it was just simply getting that visit paid for, right? And what happened? There was a whole uproar. Oh my God, this is going to lead to death panels. If you talk about death, they're going to kill a grandma. And so as a result, he pulled it the next day. And who knows what's going to happen with healthcare reform now. But it seems like if you make a benefit available to people, you give them that session. Even those perhaps who don't have the most supportive family relationships, if they get in there, they start talking in a mediated discussion perhaps with a healthcare provider, maybe it'll make some incremental benefit, again, to ensure that people receive the kind of care they want and they die in the way that they want to die. Again, and just another point again, these kind of policies might be most effective for those who are in the greatest need, and that's often our goal with public policy. Happy, healthy, rich people with lovely families probably don't need help, but those who have tenuous family relationships might be the one who benefit most from an intervention or a policy of this type. So I will leave it at that, and then we can do maybe 7 minutes or so of questions. So thank you. Yes, sir.
Question time. Is it time to ask questions?
Yeah. Please, yes.
Regarding the advanced care planning, what if someone regrets the decision made 30 years ago and is incapable of making a new decision because of health concerns presently? Is there research showing the consistency of decisions over time?
That's an excellent question. And the one kind of mantra of advanced care planning is this is something that people should do early and often. Even if you do your living will now, you should be encouraged to continually change it, and especially continually change it as your health changes, but just as importantly as your family relationships change. If you get a divorce, no, you're not going to name your ex-husband as the advocate. The problem is if someone should have a change, they don't take their ex-stepchild off, and then they develop severe cognitive impairment and they can't do it for themselves. That is one of the really tricky situations. And you'll hear stories from healthcare providers about how it's really done. And they do say that sometimes, regardless of what's in the written document, if you have a chorus of family members sitting in that room saying, do A, and the document says B, sometimes they will lean toward what the family member is saying right there. It's hard because there's what legally people are supposed to do, but then what kind of decisions are made in the actual dynamic of the hospital room or the hospice room. So again, if you're kind of stuck with something that's irrelevant even in some points, it's not going to be brought to bear. Kind of the more current information and people will be brought to bear on that decision.
What have you done in terms of how this is sort of reshaped by widowhood? Because typically people are selecting their spouses, and then they become widowed.
Yeah.
I would think there might be a big lag during which they wouldn't change those arrangements, yet now they don't have someone who's alive who can fill this role. How quickly do widows tend to begin reshaping their advanced care planning to include children as opposed to spouses?
That's a great question. I don't know if there's any data on kind of the effect effect of spousal loss on the change of given that you have one. But this comes about in a couple of different ways. Just a couple facts that inform this question. One is that I've done other papers where I look to see like gender differences in who you choose. Married women are much more likely than married men to name their kid as their advocate. And it's because women know they're going to outlive their spouse. And so sometimes at the outset, the women are more likely to tend to choose a child as a way knowing that they're going to be widowed. Another issue is that often people who have not done planning at all, which is for some age groups the modal category, other people's deaths trigger their own planning. In fact, I just had a little paper in the Gerontologist about that. If you ask people why they plan, the most common thing is my doctor said I should. I just had a heart attack. But the second thing is my husband just died and I don't ever want to die like that. Or I saw my mom die and I never want to do that. So sometimes actually a death event, especially seeing a bad death of another person, kicks us into gear. But that other question, I don't know the answer, and if anybody should know the answer, I should. I think it's partly because I could look at it, but we'd have very small cells, right? That time period of recently widowed and then whether they changed their planning. So no one really has good data on it yet. And maybe this is something, when we study these things, we talk to like lawyer audiences from time to time and financial planners. This is something the lawyers need to know. Unfortunately, when they're sitting with the sad widow and talking about the dispersion of property, they probably should say now. Now is the time that we really need to redo your living will. But excellent question, excellent point. Melissa.
I'm interested in your wistful study that you're working on, and just wondering if you can tell us a little bit, if you've looked in how you approach families and what the response has been to these family members being asked to participate on this topic.
Good question. This is,
Just repeat the question.
Oh, I'm sorry. I'm usually good at doing that with my big undergrad course. So to repeat Melissa's question, she's asking kind of about the practicalities of doing a survey like the Wistful, that you're going to a person that they kind of knew that their loved one was in Wisconsin longitudinal study because they get so many damn mailings from us, but then to come in and say, hi, we know your partner died and we're going to ask you questions about it. Honestly, of all the surveys I've done, it has been the single hardest to get a good response rate. And designing this study was very difficult because there were two different ways I could have done it. One way I thought was more logical, the other, and I thought was more logical, that for the Wisconsin longitudinal study, I mentioned all these graduates, but we also have parallel interviews with a spouse and with a sibling from years back. And my thinking is those are the ones we should target, the spouse and the sibling upon whom we have all this life history data. So I have the best kind of correlates of their reaction. But then in practical terms, I really should be interviewing the two next of kin who know the most about the death. And that's exactly how we did the screening, that for a person who died, I knew from 50 years of data who their spouse and kid was. So we called them first. And in some cases, they were kind of like taken aback. How did you know? But then we kind of explained what the study was. And then we asked them, like, are you knowledgeable to talk about this death? And for spouses, almost always they said, yes, I am. But if they said no, or for any of them, we would say, can you tell me who else in the family could talk about this? And so that calculating our response rates is just a nightmare. So if they said, no, I can't talk about this, but my daughter Judy can, then we go to Judy. And they were surprisingly good about giving us the name of another family member to contact. Sometimes they would say things like, well, let me check with her first. But it was difficult. And usually, again, another thing in bereavement research, we'll never go in for an interview any fewer than 6 months after the death because it's considered too difficult, right? They don't want to talk about it yet, but we're now supposed to go back on 12 months because it's an anniversary and they might be symptomatic at that time. So it was timing issues and then kind of getting a good response rate. In some cases, we couldn't do two, and that's fine. If it really is someone who has only a spouse and no children, no sibs, that's what we went with. But it was difficult. And another thing we did, and maybe too technical for some of you, we sent them all an advance letter. So we didn't cold call them. We sent them a letter with my cute little logo that someone designed. I sent them a link to the WLS, the main study, so they could see all the respondent reports. They could see it's University of Wisconsin. This was something to be trusted. We have a 50-year history. But bereavement studies are hard, and contacting people and saying, yeah, we know this guy died, talk to us about it. That's a tough sell unless you have like a 50-year history as we did with this project. Okay.
How much?
Oh, sorry.
How much is due to efficacy? Because not everyone knows about how to go about DPAHC. So what are the demographic differences? Because there's so much disparity in health knowledge.
Yeah, there's a ton of disparities. And be totally self-serving. And for efficiency, if I have a website and you can find a bunch of papers there, but I'll hit the high points here. I had thought that personality measures would predict this, specifically kind of conscientiousness. It didn't have any great effect. It could be that, at least in the Wisconsin study, they're all very educated and very conscientious, so it's really a non-normal distribution. The biggest predictor I found, and again, this totally speaks to policy, it's not physical health, it's not gender, is socioeconomic status, and specifically not education, assets. I found that people who own homes, who have lots of assets, they go to the lawyer to write a will. Why? They have assets to protect. You go to write a property will, they say, hey, by the way, have you thought about a living will? So there's a huge class story here. And there are vast numbers of Americans, African Americans and poor people who have no assets to protect. They're not going to the lawyer, so they don't have that initial point of contact where the end-of-life planning actually gets kicked off. And so again, another recommendation is to try to kind of hit people where they live, bring more of these lessons into churches or community organizations, but there's definitely a class issue here, and far less psychological. I had thought it would be kind of a planfulness thing, and not so much. Another is, what's the other one? Religion is an interesting one. That I thought it would be your standard, Protestant, Catholic, etc. No, it doesn't play out that way. It's religious people who are fundamentalists are far less likely to think about death, talk about death, do planning, which is kind of interesting. And I think they suspect that maybe it's in God's hands, right? We don't need to do this planning because God decides when it's our time. So funny ones. I didn't expect those to be the core predictors. Mm-hmm. Oh, sorry, I'm chatty. Okay.
This has been
yes.
great.
Okay.
Thank you.